Hi, good evening, everyone. I hope you're doing fine. Today was really a very tiring day, and sorry for being late. Just finished off the surgeries right now, and after that there were 2-3 patients on OPD also, so I got just late. Even I did not have uh, my dinner also. So let us start this session. Let us start this session. Okay, but before that, do give the exams, and we are also launching the daily practice papers. So do give those things. And we have some prof batches also coming up, which are very, you can say, good for the youngsters for the first years. So let us quickly start this. Okay, identify the maneuver shown here being done for securing airway. So this is not for airway. So identify the maneuver being done for the airway. Identify the maneuver being done for the airway. Excellent, 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 excellent. This is what this is not jaw thrust, students. This is a chin lift. So this is chin lift. This is neck tilt. And this one is jaw thrust. Jaw thrust. So we have jaw thrust, we have neck tilt, and we have chin lift. So jaw thrust, neck tilt, and chin lift. So they are the three very important things that we have to understand. Now, how do we secure airway, and what is the need to secure airway? Let us try to understand all these things in theory. So, bachcho, let us talk about the concept of patient survey. So, when we talk about patient survey, what are the important things in patient survey? So, bachche, patient survey, we actually follow the concept of ATLS. In patient survey, we follow the concept of ATLS. And when we talk about patient survey, it is of two types. It is the primary survey, and it is the secondary survey. So we have primary and we have secondary survey. What are very important things that we have to understand is, what are these patient surveys? This is the first clinical assessment done. So whenever a patient visits the emergency, the first clinical assessment which is done, this is what is known as patient survey. And what about the secondary survey? This is clinical assessment. This is clinical assessment done post hemodynamic stabilization. So clinical assessment done post hemodynamic stabilization. Now when we talk about the aim of primary survey and the aim of secondary survey, it is very important for us to understand what is the aim of primary survey versus aim of secondary survey. The aim of primary survey, when the first time when the patient is being assessed, we are not interested in what happened with the patient, how it happened, who is he, who is she. No, not at all. We want to rule out any life-threatening injuries. So to rule out any life-threatening injury. To rule out any life-threatening injury. This is what is. So to save the life of the patient, this is the priority of primary survey. Then what is the secondary survey? But in secondary survey, we find out ancillary information, like maybe the patient is diabetic and on insulin, maybe the patient is antihypertensive, maybe the patient is on blood thinning agents. So to improve the outcome. So to improve the outcome, or you can say to modify the outcome. So to improve or modify the outcome, this is what is the aim of secondary survey. Students, when we talk about primary survey, what are the important things that we have? So when we talk about primary survey, what are the important things that we all have to understand? Let us see this. In primary survey, the first most important thing is, after securing airway and stabilizing signs. Students, what would be the immediate cause of death? It is an airway compromise in trauma or a jeopardized cervical spine. So after securing after securing airway and cervical spine So after you secure airway and cervical spine, you start with the assessment of airway system, breathing system. So let us see how do you secure this airway. We secure airway, I have already told you, by chin lift. Students, in securing airway, if you see airways, the anterior part, this is the trachea and the airway system. So you need to extend the neck. So this is a very common question. I've seen a lot of students being mugging up. Remember, if you want to intubate the patient, neck should be extended. If you want to put a Ryle's tube, what should be straightened? The esophagus. So neck should be flexed. So intubation, extended. Flexion in case of Ryle's tube. Is that clear? So chin lift, jaw thrust, and neck tilt. These are the three things. How do you stabilize the cervical spine? Now this is again very important. How do you stabilize the cervical spine? By use of what? Philadelphia collar. So with the help of hard collar, and this collar is known as what? Philadelphia collar. So after you do the securing of airway and cervical spine, now you have to start assessment of A, B, C, D, E. So assessment of A, B, C, D and E. Now what is the difference of this A, B, C, D and E? This is airway, this is breathing. Now there are a lot of students who are often confused between this airway and the breathing system in this. And then C is your circulation, D stands for disability, and E stands for exposure of the patient. Now, bache, airway is a common inlet of the oral and the airway tract. That is the oral vestibule. Is that clear? Now, once the trachea starts, any injury at the level of trachea, we just take it to the breathing system part. Are you getting? Now, students, there is something which is known as C, A, B, C, D, E. And there are a lot of people who say that nowadays the ATLS has upgraded itself. And this C, A, B, C, D is not the rule. We give priority to the circulation first. But they are morons, and you people don't become moron. What does this C stand for? Try to understand the aim of primary survey. The aim of primary survey is to save the life. So any catastrophic cause of bleeding has to be controlled first. Suppose if you have a patient with a laceration wound of the, you can say, of the wrist where the patient is bleeding profusely, will you start with the drama of airway breathing? If the patient is actually having airway problem, you may go for that, but then you will have to put a tamponade over this bleeding vessel, isn't it? So the C stands for control any catastrophic bleeding if present. So control any catastrophic bleeding if present. Are you getting? And this is very important. Control any catastrophic bleeding if present. Yeah. I've already told you, Venkat, I've already told you. Airway is the common inlet, the oropharyngeal cavity, that part is basically compromising this airway. So suppose after trauma there is a maxillofacial injury because of which the nasal, you can say, vestibules are blocked. Because of hematoma also, it could be blocked, of clot also. This is what is airway. Breathing, when you talk about, we go at the level of trachea and the bronchial tree. This is what is the difference. Is that clear? So we have just seen the primary survey. Now the next very important thing is, what about the resuscitation? Always remember that the primary survey and resuscitation, they go hand in hand. So primary survey and resuscitation, they go hand in hand, and therefore one very important thing is, in resuscitation, the question is cannula. What is the cannula of choice? What is the fluid of choice? What is the fluid rate of, what is the rate? These three things you have to always master it. So when we talk about cannula, there are a lot of questions being asked on cannulas. So cannula, on one side you will write the size, and the size is taken in gauze, the gauze, and then color, and then flow rate, and then use. So these four things are very important. Students, we start with 14G, that is orange, and the flow rate is 240 ml per minute. Then we go to 16G, that is gray, and this is 180 ml per minute. Then we have 17G, that is white, and this is 120 ml per minute. Then we have 18G, that is green, and this is 90 ml per minute, last INICET question. 20G, this is pink, and this is 60 ml per minute. 22G, we have blue, and this is 45 ml per minute. 24G, we have yellow, students, and this is 30 ml per minute. 26G, we have violet, and this is 15 ml per minute. Are you getting? So this is the flow rate. Now, whenever you have to write about cannulas, now I've seen a lot of students giving me a vehement answer that you can use this cannula. But say you have to see what is the patient category you are dealing with. So blue, yellow and violet, they are for pediatric age group. Yeah. So pediatric. So they are pediatric. Then pink is for all IV infusions. All IV infusions. Then we have green. We have green. When we talk about green, what is so important in this case of green? Anyone? This is for all surgeries. All surgeries. Then what about 17G? 17G. This is white. When we talk about white, this is white, grey and orange. They are all for rapid resuscitation. They are all for rapid resuscitation. Or you can say this is for trauma also. Are you getting? This is what. So I hope cannulas are clear to everyone. The next thing is, let us talk about the fluid rate. Now, bache, when you talk about the fluid resuscitation, there are 2-3 things. What is DCR? DCR stands for damage control resuscitation. Damage control resuscitation. And the another one is, students, we have the maintenance dose. The maintenance. So there are two different concepts. What is the maintenance rate, and what is damage control resuscitation? But when we talk about damage control resuscitation, the first principle is limited use of crystalloid. Don't overload the body with crystalloids. So limited use of crystalloids. Now the question is, sir, how much crystalloid shall be apt? Up to 2 liters. Up to 2 liters. Out of this 2 liters, 500 ml to 1000 ml in bolus. 500 ml to 1000 ml in bolus. Are you getting? The next very simple is, try hypertonic saline instead of the conventional fluids. The next is, if you need to transfuse, don't infuse fluids in form of crystalloids. Go for blood. So use of blood and blood products. So use of blood and blood products. So fourth. So use of blood and blood products. Try hypertonic saline. Limited use of crystalloids. The next very important thing is permissive hypotension. Students, whenever we are resuscitating a patient in trauma bay, we don't rush for the blood pressure. Very good Venkat. So permissive hypotension is the rule. What is the target map? Because higher the blood pressure, more rapid will be the blood loss. So the target map is taken as 65 to 70 mmHg. 65 to 70 mmHg. Yeah. So limited use of crystalloids, try hypertonic saline, use of blood and blood products, permissive hypertension, and the next very important thing is use of cryoprecipitates, use of cryoprecipitates, use of tranexamic acid, and then use of recombinant factor 7. So why recombinant factor 7? To strengthen the extrinsic coagulation pathway. Now what is the fluid requirement in maintenance? So whenever we talk about maintenance fluid, how do we see? We have two things. So maintenance fluid volume requirement. So if we talk about volume requirement, we have two formulas. What are they? In ml per day and ml per hour. So ml per day and ml per hour. ml per day and ml per hour. Now when you talk about ml per day versus ml per hour, we have first 10 kgs, we have second 10 kgs, and we have further kgs. So first 10 kgs, second 10 kgs, and further kgs. But what is the formula for fluid requirement for ml per day? 100 ml per kg for first 10 kgs. 100 ml per kg for first 10 kgs. 50 ml per kg for second 10 kgs. And then 20 ml per kg for further kgs. So isn't it easy? 150 20 150 20 in ml per hour. If we see 4 ml per kg for first 10 kgs, 2 ml per kg for next 10 kgs, and 1 ml per kg for further kgs. So 150 20 4 to 1, 150 20 4 to 1. Okay, so example, if we see the volume requirement for 80 kg individual students, 80 kg individual, so it should be 100 for first 10, 50 for next 10, 20 for remaining kgs. So if you add, this is 1500 and this is 1200, so total is what? 2700 ml per day. 4 ka 1. Yeah. Next is if you talk about 80 kg in ml per hour, 4 ml for first 10, 2 ml for next 10, and 1 ml for remaining kgs. So if you see, this is 60 and this is 60 and this is 120 ml per hour. If you see, there is always a difference of, you can say, few mls if you calculate it via what? Ml per day versus ml per hour. Why? If you multiply 120 by 24 students, you'll always get a higher value with 100 in ml per day. If you convert it into what? Into ml per if you convert this ml per hour by multiplying it by 24, you'll get a bit high value. Why? Ideally this 4 ml should have been 3.8. In order to make the things easy and memorizable, we have rounded it off to 4. So 4 to 1, 150 20. 4 to 1, 150 20. Is that clear or no? This is very, very, very simple. The next is flow rate estimation. So rate estimation. So we have seen volume. Next is rate estimation. When we talk about rate estimation, there are 2-3 things that you have to understand. Volume rate in estimation is defined as drops per minute. So drops per minute, we have 2 tricks. This is volume in ml per day divided by 100. or it is volume in ml per hour divided by 4. So if you see here students, 2800 ml per day, how many drops per minute? If you divide it by 100, you'll get how much? 28 drops per minute. 5600 ml per day, how many drops per minute students? It is 56 drops per minute. Similarly, if it is 200 ml per hour, how many drops per minute? 200 divided by 4 is equal to 50 drops per minute. Then we have 400 ml per hour. This is equal to 400 divided by what? 4 is equal to 100 drops per minute. Are you getting? This is how the things are. This is very simple. So we have seen the primary resuscitation, and along with that the maintenance fluid concept also. So resuscitation in trauma bay is totally different from the conventional, and this is how the fluid requirement is calculated. So students, I'm actually not feeling well today, so I'll stop it here. I have planned it for a longer time, so tomorrow I'll take it for a longer duration. But appendicitis ka revision short mein I'll do it tomorrow, because I think I'm having a bit of hypoglycemia and I'm having a very severe headache. So I'll have something, and tomorrow I'll definitely do a quick revision for this topic also. Okay? So I hope I'm disappointing many of you, but I'm sorry for that. Huh? Chalo, we meet again, and do join Unacademy. Use the code Dr. Dixit to get some extra discounts, and you can also use Surgery Live. Do recommend Unacademy to your friends, and do follow me on Unacademy so that you don't miss the notifications of my classes. Yeah. So I'll take tomorrow. I'll take it. Okay.